Hello and welcome. My name is Joe Caramelli. I oversee grand rounds for the Department of Psychiatry and Behavioral Sciences here at the University of Washington. And thank you for joining today's grand rounds presentation. So for this academic year, we've developed a theme for our grand round series called Next Steps in Care. And this is a series of presentations on innovations and updates in clinical care. And today, an innovation in care about improving delivery of mental health care to older adults in general, updates on that, strategies, and so on. Now, there's a core group of us working on grand rounds, including 2 departmental staff members, Semhar Abraha on coordination and communications, and Mike Walker on technology. We do archive the presentations on the grand rounds website. And I want to acknowledge funding sources for the Grand Round series for this year, including the Ripley Fund and institutes in the department, such as the Garvey Institute for Brain Health Solutions. I'll put a link for Grand Rounds evaluation and feedback into the chat towards the end of the presentation. I'd encourage you to complete that evaluation of 3 or 4 questions. And you're also welcome to write to me directly with any comments or feedback about Grand Rounds. And I'd like to stop there and turn it over to colleague Dr. Patrick Rowie to introduce today's speaker.
Thanks, Joe, and I'm very happy to introduce Dr. Sairi today. I have been a friend and a colleague of Dr. Sairi since 1996, when I joined the Institute of Geriatric Psychiatry at Cornell Medical College. Sorry to date us both, Joanne. We first worked together on a study that was led by Barry Myers on mental health treatment of both younger versus older adults in community settings. And then we went on to, with numerous collaborations, focus on developing and testing psychosocial interventions for older adults with depression. And we've continued to collaborate since my move to the University of Washington, most recently on a collaborative R01 that's testing a lay-delivered behavioral activation intervention among senior center clients that we call Do More, Feel Better. Joanna is a real leader in the field, specifically in the area of community-based research for older adults with depression. And one of the main themes of her work is really integrating mental health services into non-specialty settings like aging care settings. So I know she's going to talk a lot about that today. Joanna is currently the PI of the Weill Cornell Alacrity Center. Joanna is a wonderful colleague and also a very dedicated mentor to numerous junior investigators. And I'm really looking forward to her talk today.
Thank you. I really appreciate it. Thank you for the kind words, and from a longtime collaborator and friend, it means a great deal. So I'm really happy to be here and to talk to you a little bit about work that I'm doing. And you covered my current funding, which is great. We also have some money from DOJ and the Department of the Aging, and I will not be talking about off-label use of anything. So I have no financial conflicts. Actually, what I am going to talk to you about is kind of 2 bodies of work, our NIMH-funded intervention research and some service delivery projects. And this will be kind of a broad array of projects without too much depth on any of them. So forgive me for that, but I really kind of wanted to, present the lay of the land of what we're doing. I think one of the things that's really important is the overall, kind of aim of these projects is really to advance health justice and behavioral health, and really by kind of improving access, engagement, and outcomes. And so our objective, no matter whether we're doing service delivery or we're doing research, is really to improve the engagement of older adults in mental health services and hopefully improving the outcomes for them. So that's kind of the big agenda, if you will. So I'm going to start a little bit talking about the research focus, and then we'll move to service delivery. And our initial real kind of earliest work, and yes, Patrick was a big part of this as well, which is really nice, was really looking at barriers to quality care, the kinds of things that stand between individuals who are based mostly in community settings and their access to mental health services. And then we really began to move to developing interventions to kind of improve both access, engagement, and then outcomes as well. And as Patrick mentioned, most recently, we have an R01, collaborative R01, that's at University of Washington, Cornell, and University of South Florida, which is really looking at peer-delivered interventions with the eye of thinking about workforce expansion. And I'm not going to talk about that project because we are launching that now and we don't have outcome data quite yet. So, you know, in terms of barriers to care, we began with kind of one of the most notable individual level barriers, which is looking at perceived stigma and the way in which stigma affects access to care. We documented early on that stigma was associated with dropout, non-adherence, and interestingly enough, not just guiding the individual's behavior, but we also had a project where we documented that high stigma in an older adult in a community setting decreased the likelihood of that individual actually getting the referral. So it was not surprising to the clinicians, affecting the engagement of the clinician and the willingness to offer the referral. We worked on developing a stigma scale to really help older adults think about what they were anticipating in the way of stigma, and developed a scale to kind of measure the sorts of services they were using. And this work was, a lot of this was my Career Development Award, focusing on the barriers to stigma to try and kind of help identify those barriers. The other thing that's kind of worth noting is that the World Health Organization in 2014 noted that actually the attitudinal barriers were more common than structural barriers amongst those individuals who had mental health need. So while we often think about structural barriers like how close is the clinic to the individual, I think we also need to think about the attitudinal barriers. The other thing that's important about attitudinal barriers is they offer a potential for modification, something we might be able to do something about. So as we began to kind of think a little bit about these barriers, obviously as clinicians, it prompted the next question, which is, can we do something about this? Can we improve engagement? Could we get people into treatment? And that led us to this very colorful but kind of simple model of how I think about care. That on, you know, kind of on the left-hand side, there are the person level factors, and that, you know, whether somebody their need is identified and whether the referral is made is an important part of whether they get access to care. But even once they do kind of get access to care and the referral is accepted, how do those attitudes and beliefs and treatment preferences affect whether or not they engage in care and the outcome? And you know, because of the context I was working in, we really began with this question of, once people got into care, could we improve the way in which they engaged with care, and began to look at adherence. This was a randomized controlled trial, multi-site study with us and our colleagues at the University of Michigan. Helen Kales was the PI there. And it was a randomized controlled trial test of a brief intervention to try and improve adherence to antidepressant medication being prescribed by a primary care doctor. So we randomized individuals who were being seen in primary care at these two different locations to either receive what we call the TIP intervention, treatment initiation and participation, to either receive TIP or treatment as usual. We did not control the number of visits with the primary care physician. We didn't control the antidepressant medication. The question was really, if we did this brief treatment, which was 3 sessions, 30 minutes each, talking to individuals specifically about their goals in terms of adherence, their ability to adhere, how they remembered their medication, with the objective of helping them kind of develop a strategy to be adherent. And did that actually enable them to be adherent? And adherence was defined as 80% adherence, both 6 weeks and 12 weeks after the treatment was begun. And we actually measured that using a self-report and found that actually that brief intervention really focused on adherence, improved adherence at both 6 weeks, 6 and 12, and 6, 12, and 24. So it was pretty notable that at the 6-week mark, very early in treatment, those individuals who met with us, and they would have met with us during that first 6 weeks of treatment, week 1, week 2, and week 4, were 5 times more likely to be adherent to their treatment. And that really, I think, argued for us that you could really begin to talk to people about the barriers they were facing, work with them to improve their engagement and care, and potentially drive outcomes with these kinds of brief interventions. So then it really led us to this other question, which is what happens to those people who are not already seeking care? They haven't crossed into primary care, which is really in many ways the de facto mental health service for older adults. Could we help those individuals who are kind of out there, but in need of care, get into treatment? And this actually led to my second R01, which was really focused on improving access to care. So trying to kind of improve the crossing over of that red dotted line. And again, using the similar sort of perspective, could we, in a brief sort of way, meet with individuals and help them accept a mental health referral and attend an initial visit with a mental health provider? And it's very interesting because this is very much a part integrated in the current work that I'm doing, the service delivery projects that I'm doing, because I go out to the community and train case management staff about how to make a mental health referral using this model of identifying barriers, setting goals, and supporting a referral, and really begin to teach them this concept of a cost-benefit analysis, which I believe everybody really does with a mental health referral, as well as a health referral, in terms of how they make decisions about whether they're going to follow through. And we compared that to an attention control because we were concerned that it could be just meeting with the therapist that could be making the difference. And we found that both our intervention and depression severity predicted treatment initiation. And again, I think to me that makes a lot of sense, because really what you're saying is, if you intervene and at the same time the individual has some sense of distress, that combination of both the distress and being able to kind of articulate what the barriers are and set goals, that really is predictive of treatment initiation. We also did an analysis of individuals who endure suicidal ideation, because that's the population that's of particular concern to case management agencies. And while we had a small subgroup, we did find that the rates of engagement were fairly higher among those who got open door versus the attention control. So it really kind of argued for us that we really could work with these kind of agencies that are providing aging support services and really help them kind of transition those clients that needed it into mental health services. I'm happy to say that what ended up happening was that the New York City Department for the Aging, who we began to have some dialogues with, really saw this as an opportunity for them to bring mental health services and mental health interventions into their aging support agencies, and in a number of different ways. The New York City Department for the Aging is the largest area on aging agency in the country. And for us, partnering with them really enabled us to expand our work in a very kind of partner-focused sort of way, both our service delivery work, which I'll talk about, but also the research to kind of really build research programs that had meaning to the individuals who were actually serving this older adult population. For many people, this is not the world they live in. And so just so if you're not aware, the Aging Services Network provides a wide range of services from referral and outreach to elder abuse services. And I highlighted the areas where we're working, but they really provide a tremendous amount of services to older adults in very many different sorts of venues and settings. So this kind of partnership and this question about could we serve older adults and provide mental health services really led us more to our service delivery projects. You know, their interest in providing, you know, supporting independence for people who want to live at home, and our interest in believing that addressing mental health needs helped promote that mission really made for a very nice partnership. And what I'm going to tell you about is 3 projects that one is completed and the other 2 we're still working on that are in partnership with our friends at the New York City Department for the Aging. So about just some perspective, 20% of New York City adults are over the age of 60. And over the last 10 years, New York City's seen a significant increase in older adults of color, those living below the poverty line. And 47% of seniors do not have English as their primary language. So it's an extremely diverse population. So in addition to whatever barriers we might be finding with mental health, we also are looking to provide mental health services that is diverse and meets the needs of the community. So our first foray into this work was after Hurricane Sandy. And I had the pleasure of working with Patrick on this project. We obtained FEMA funding with the New York City Department for the Aging to provide mental health services to older adults living in impacted areas. And this is actually a very interesting opportunity for us to kind of get into the world of service delivery and to partner directly with the New York City Department for the Aging, who's interested in different questions, but related questions. You know, what kinds of services were these individuals using after the storm? What did they lose access to? So the objectives behind SmartMH were really to see if we could figure out the aging service and mental health needs of this older adult population. And to do that, we actually put a series of things together. It combined kind of outreach, working with senior centers, faith-based communities, local providers, pharmacies, you name it. Anybody who would talk to us, we kind of went out and talked about this program. For older adults, anybody who was living in the impacted area, whether they had a mental health or aging service need, it didn't matter. We wanted to do an assessment of them. And that was both a general needs assessment, but also an assessment of depression and anxiety. We used the open door strategy to make a mental health referral for those people who had mental health need. And we did something that New York City had never, ever done, which was we offered free brief therapy and located it at the senior center. So we set up an arrangement where they would give us some private space and we would interview their members. We would see those individuals who had mental health need and were depressed or had suicidal ideation, and we'd offer them free brief treatment right then and there. We were lucky because at the same time that we were launching this project, Dr. Alexopoulos and Dr. Arian were testing Engage therapy developed at the University of Washington and Cornell, which is a reward-based therapy, stepwise intervention that usually involves 8 sessions. And they were doing a formal evaluation of this model with our own funding. And we decided to take that intervention and just distill it down to basically 6 sessions mostly because we weren't really sure whether people at senior centers were going to be willing to accept a mental health service in a place where they go for chair yoga, or they go for meals, or they go for health promotion information. And so we thought actually a 6-session model would make more sense in terms of being an easier lift. I'm pleased to say that Patrick did the training and supervision for the Engage therapy that was being offered. And we offered the therapy in a number of different languages. So we interviewed many older adults, 2,831 individuals in Chinese, Russian, Spanish, or English, mostly female, diverse population. Many of them had health problems, and they were very forthcoming about their concerns about worrying about another storm. And actually, as a result of Hurricane Sandy, New York City redrew their flood lines because I don't think the city had ever been impacted in quite the same way. And the older adults really were quite forthcoming about their experience of that. We found that about 12% screened positive on the PHQ-9 for depression, which was a little bit higher than what had been seen in New York City up until that point, although not significantly higher. And we found of those individuals who screened positive, 1/3 were already in treatment. Not an uncommon phenomenon where you find somebody who's talking to you about having a profile of symptoms, and yet at the same time, they're talking about also being in treatment at the same time. And for those individuals, we kind of coached them and said, hey, you should go back to your provider, your psychiatrist, your psychologist, your social worker, whoever you're working with, and let them know that you are experiencing these symptoms still. Hopefully kind of maybe encouraging them to share that if they hadn't already. Of the remaining individuals who were not in treatment, a fairly high number agreed to receive this brief 6-session version of Engage therapy at the senior center. For those of you who make mental health referrals, 70% is extraordinarily high, so we were pretty pleased. And we weren't surprised in some sense because we were offering therapy in their language for free at a center that they were attending. So a number of those kind of structural barriers that I talked about earlier, but also by integrating it into the senior center, you could conceptualize this as a mental health service that's kind of in line with some of the other services being seen in senior centers. And maybe that also decreased some of the stigma. We did find, now again, this is a service delivery project, so there's no randomization, there's no control group, but we did find that the PHQ-9 scores from the start of Engage, the 6-session Engage, to the last session did decrease. And I don't think I actually have it in the slide deck, but we also looked and did a very extensive review of the literature and found that the decreases that we were documenting were very consistent with other decreases documented in other therapies and other settings using the PHQ-9 over the course of therapy. So we did feel like we were seeing trends that were similar to what was being seen in research projects. We also were particularly interested in serving diverse communities, so we really wanted to divide this up to make sure that the individuals who are not English speaking, who are getting engaged in a different language, were having the same response as those who were doing it in English. So that was really kind of important, and really our foray into offering mental health services at senior centers. And it was an important project for us because it solidified our partnership with DFTA. We developed very strong relationships with New York City communities. I'm still actually running into people that I met during that time. And it also really documented to us that if you brought mental health services out to the community and you offered staff who were culturally sensitive and spoke the language of the community, that you really could engage communities that had challenges in other reported challenges in terms of accessing care. So we thought this was an important project for us, and it also for New York City Department of the Aging, which again is an aging service provider, it really became for them a template for new initiatives. It documented for them that they really could think about integrating mental health services into this senior center setting. And that's kind of was an important change. It actually led to this model, the SmartMH model, being sustained and expanded. In New York City, we have just gotten a new mayor, but our previous mayor, Mayor de Blasio, and his wife, Charlene McCrae, prior to becoming the mayor and the First Lady of New York City, had mental health experiences where they tried to find mental health services for their adult daughter, their parents, and went down the rabbit hole that oftentimes people do go down when they're trying to access mental health services. Insurance, wait lists, difficulties finding the right provider for an adolescent girl or an older adult, and really decided to tackle this question. And it's kind of a remarkable step because New York City is not the place that you would imagine testing new models of mental health services because of the size of it, because of the diversity. But they brought a mayor's fund to advance New York City's mental health services and develop 54 initiatives that range from, older adults in senior centers to integrating into the schools, primary care. This is known as Thrive NYC, and I think has really changed the face of mental health services in New York City quite dramatically. For New York City older adults, it meant rolling out mental health services in senior centers. So they began with 48 senior centers. And they included the mental health components that we had in SmartMH, the outreach and engagement, the assessments, and direct therapeutic services. They added something that we didn't have, which is that they built in billing for services. And they did that primarily because they were concerned that a new mayor would come in and would not want to necessarily support this program. And so they built in billing for sustainability reasons. This funding is now baseline funded, and we are hopeful that the new mayor will continue this, but it is part of the baseline profile of monies. And we also believe that actually a program that brings in some revenue, albeit a small amount, might be harder for them to cut. So we're kind of pretty excited about that, and really feel like the SmartMH experience really kind of laid the groundwork for DFTA, our New York City partners, to implement this kind of larger program. So while Cornell is the mental health provider in 2 of the 5 New York City boroughs, we currently provide mental health services. And again, this is a contract to Weill Cornell to provide mental health services at senior centers. We integrate a bilingual clinician into the senior center 2 days a week. That person's role is to provide education, to talk to staff, to meet the seniors, to do these assessments to help determine which older adults might need mental health services, as well as to be there when an older adult kind of refers themselves over for mental health services. And the idea is really much what we saw in SmartMH, which was really to integrate mental health into the senior center services, thereby potentially reducing the stigma of going for mental health services. I can tell you that initially the centers were based on size. They were the largest of the centers, and we are one of 4 providers. They were divided up by borough, which seemed to be the easiest. Manhattan has a different provider, and the Bronx has a different provider. And we at Weill Cornell got the largest number, and we have Brooklyn and Staten Island. Brooklyn is the largest borough in New York. We also are providing some psychiatric evaluations and some medication treatment, kind of launching medication treatment for some clients that are already in therapy. So it's a kind of mostly a therapeutic model, but we're also doing some medication management as well. So we call it TRIO because we believe that it brings together an awareness of the need for mental health, aging, and mental health, aging, and health services to kind of promote successful aging. Right now, everything is virtual. We shut down in-person services March 13th, 2020. And we have been, our senior centers have opened only a little bit recently. They opened to 20% capacity recently. But mental health providers in this program are still working virtually. And because we have been hit very hard by Omicron, many of the senior centers, I would say the vast majority, are closed at this moment as well. And they are providing meals, kind of, take home meals, or what we call grab and go. We have 9 clinicians working on this program. Most of them speak another language. They've done a lot of engagement outreach groups and served a number of people in that way. They do a mix of short-term and long-term treatment and roughly about 100 visits a week. And we've seen some pretty significant decreases in depression and anxiety over time. We reassess people every 3 months. So for our senior centers, most of them, the people we're serving are female, consistent with the senior center population, mean age 74 years, again, a diverse population. Most of them are living alone. And you can see that the rates of PHQ-9 positive and anxiety on the GAD-7 are higher. And again, part of that has to do with a selected sample, because some people do come to us looking for mental health services. So we definitely expected higher rates. We do find that individuals endorse an elder abuse experience, because we're screening for that as well. And 1 in 10 people are struggling with hoarding and are unable to use at least one room in their apartments. So there is pretty significant mental health need being documented and served in this population. And I think the value of this has really become a very successful program. And for us, we will be expanding to an additional 14 centers, which gives us a total of 30 centers. And we'll be targeting populations that were hit the hardest during COVID. The previous mayor, Mayor de Blasio, put together a task force on racial inclusion and equity to identify those neighborhoods that were really having the greatest difficulty serving their older adult populations. And so we are embedding our services in those populations. What you see is actually my map of the red centers are the centers we're in, and the green centers are the centers we're going into, and some of the neighborhoods that we're going into in Brooklyn and Staten Island. So this is really a partnership that began with a targeting of individuals who were hit by a major disaster, but it's really morphed into an integration of mental health services into senior centers, and a real model that's being sustained in New York City at this point, and growing over time. So it's actually pretty exciting for us to be serving these older adults in New York City. So now I want to kind of turn again to a different population. We were talking about senior center participants, and now I'm going to talk to you about elder abuse victims. What you actually see is a picture of one of the outreach campaigns that New York City did, where they did these incredible posters that were quite striking and put them on buses and subways to really raise the awareness of elder abuse. So in New York City, elder abuse is handled in a different way than it is in most of the rest of the country. New York City has, well, New York State has no mandatory reporting. So we're one of few states that is set up that way. And we have this kind of divided system where individuals who are experiencing elder abuse are served in two different ways. If the individual is capable to make decisions, to accept services or reject services and has capacity, they're served through the community-based agencies, the CBOs, and those individuals who are viewed as not having capacity to make their own decisions, mostly because of suffering from dementia, but not only, are served by adult protective services. This is not the case nationally. Most elder abuse victims are served by adult protective services that are embedded in, sometimes they're in social services, sometimes they're in aging, and they serve all populations. But because I think the numbers are so huge in New York City, they've kind of divided this up. And I tell you this because we work very closely with the community-based agencies, and we've targeted depression amongst this older adult elder abuse population. This is particularly important because other researchers have documented that depression amongst elder abuse victims is associated with mortality. And I think if you think about it from a more intuitive service use perspective, you could see that the symptoms of hopelessness and helplessness and lethargy that could be characteristic of depression might really interfere with the ability to accept the elder abuse interventions being offered by an elder abuse caseworker. So who might say, let's change the locks, let's get an order of protection. And if the individual is depressed, they might have additional difficulties implementing these safety interventions. Elder abuse service victims are asked to do difficult things to begin with because by the nature of elder abuse, it's a trusted family member or a trusted friend. And so it's quite a difficult thing to begin with to obtain an order of protection against somebody you love and trust. And so you can imagine that depression would make it more complicated. So again, our friends at DFDA who had this expertise in elder abuse reached out to us at Weill Cornell, and we began to put together an intervention that would really target depression and anxiety amongst elder abuse victims. We began with this question of could we even integrate a mental health service into elder abuse? And that was a genuine question. Could we teach elder abuse caseworkers to screen for depression and anxiety when they found an individual who needed mental health intervention? Would the individual accept this as an opportunity to support the work that they're doing? And so we did some very early preliminary feasibility work just to document that it could be done. And that was actually a pretty important preliminary work that just said, yes, we can work in this population, which was good to know. So that original work was funded by the Samuels Foundation. And now what I'm going to tell you about is some work that's being funded by our Alacrity Center. And again, more of a service delivery project. So we developed Protect. We began with offering problem-solving therapy and then found that that was a bit more challenging to train therapists on. And we began to shift what we were doing to focus on something that was more in line with our Alacrity Center, but a more behavioral therapy that's focused on goal setting and reward exposure. So getting people engaged in activities and with people that were gratifying for them. And we wanted something that would be both easy to learn and felt like we wanted victims to be able to use whatever problem-solving skills they were already using. So we began to test this intervention with 2 agencies, one in New York City and one in Westchester, and added some smartphone technology to track mood and conversation. And actually more recently, we've added a wearable. The intervention is 9 sessions that was done in the home, although these days we're all virtual again. So the model is that the agency screens for depression, they obtain permission, they refer the victim to Cornell. We reach out to them, we do informed consent, and then they were randomized in our first project to either protect the intervention or a community referral. And given what I've told you about the emergence of mental health services, community referral really meant a community referral because there really were opportunities to provide elder abuse victims in that controlled condition with mental health services. It wasn't kind of nothing. And we did follow-up interviews at 6, 9, and 14 weeks after randomization to evaluate outcomes. We were happy to find that there were important and significant differences in depression severity for those individuals who participated in PROTECT versus the referral out to the community. It was a 2-to-1 randomization, so 25 people got, again, much to the happiness of our partners. So 25 people got PROTECT and 15 people were referred out. So that's, kind of a wonderful, that's great pilot data for us, and we're really excited. And the community did what the community does, which is they often say to us, gee, that's really nice that you want to do a randomized control trial, you want effectiveness and efficacy with your interventions, but we really want to take your intervention and run with it. And so they are partners at New York City Department of the Aging. And again, with support of this Thrive NYC, developed a contract for us to provide PROTECT throughout New York City to victims. Again, not a research project. Individuals are exclusively getting this intervention. And we are doing the same intervention that we had been doing with the research project in the community. We also got a Department of Justice grant prior to the pandemic to deliver this intervention via video. And then that turned out to be, needless to say, quite helpful. And then, of course, COVID shut us down in March 2020. And that's really changed the delivery of services because our elder abuse victims often have a hard time finding an opportunity to talk to us. So this is a little bit about the population that we're serving now. We've seen a large number of referrals in the last almost 2 years. Again, diverse population. We're delivering the intervention in Spanish as well, which is nice. It allows us to serve a more diverse community. And in the lower corner is the mayor's wife launching this program. And we're finding that many of the victims have current threats still. They're reporting multiple types of abuse. And in this actual contract, as compared to the research project, we're also seeing more women of color in this project, and also more cases of sexual abuse than we had seen in the research study. So there is something different in terms of the population that we're accessing who might not have been accessed or might not have accessed research. So it does feel like we're serving a diverse population. And we've actually found that we can see decreases in PHQ-9. This is actually a graph that shows both those people who came in with PHQ-9 scores greater than 10 and those below. At some point, we were only accepting people PHQ-9 scores of 10 or greater. And then during the pandemic, we just took all comers because we really couldn't turn people away. And this is, we found that actually it was still helpful to them. So coming down the pike, we are, as I said, expanding TRIO to these individual other areas that are underserved. We're working with crime victims now, as well as elder abuse victims. New York City Department for the Aging and the NYPD are building a partnership And we're beginning to work with Sarah Zaza and her group on looking to see if we can kind of expand to use some social engagement interventions using technology. So, you know, it's kind of a story of engagement and adherence at the individual level, and really paying attention to barriers and goal setting, and then really thinking at the systemic level, being able to integrate mental health services into settings where older adults are being seen, and tracking to make sure that we're seeing positive outcomes as they are being kind of served when we're talking about these service delivery projects. So we are tracking to make sure that we're seeing the same results in these projects that we saw in our research. Obviously, partnerships are critical, and our multilingual, multicultural clinicians are key. And I really do think that it's a story of synergy between you know, service delivery and health service programs and research, and the way in which we can do both. So there are a lot of people to thank. I have some great collaborators, some great staff, research staff, and they're, you know, out all over the place. And then of course we have our partners in other places that we do a lot of great work with, and you know, it really does take a village. So I think at this point, I'll stop and be happy to answer any questions.
Well, thank you, Dr. Sari. It's moving from stigma, barriers, adherence, through now citywide interventions, really in locations that, you know, very few, I mean, most of us don't practice it, but there's elevated prevalence of depression and other stressors which are addressable. It's very interesting to hear about. I want to encourage participants to write in with any questions and comments. While we're waiting for that, maybe I'll just pose a question. I was wondering about the Engage area. You had interviewed almost 3,000 people, which I just was floored by. I don't know how that was done over such a short time frame. That's remarkable. 12% elevated depression symptoms. And what was it that 70% agreed to engage, to start treatment? Is that what it was? Oh,
Yes.
okay.
Yes.
Okay.
And again, I think because the treatment was free, it was located at the place that we were actually seeing them. It, you know, it really enabled them to be a part of this program, which is very different than, gee, you're depressed, you should go, which of course we never speak to people that way, but you know, based on what you've told me, I think you could benefit from a mental health service, but you have to go over there and you have to go to a different system and talk to different people. And that's a big barrier for a lot of people, not the least of which is older adults. You know, so whether it's stigma or it's transportation or it's finances, I think we were able to overcome some of those barriers. And I think this new program is really designed to do the same sort of thing.
I guess as others are writing in, just to continue on that, so people actually come into the senior center and that's where the treatment occurs. It's actually
Yes.
on. And is there like an exam room, or in what way, I guess concretely, in what way is it?
No, it's a good question. So we require a private room, 4 walls and a door that can be dedicated to the clinician on the 2 days that that clinician is there. And it really does have to be like walls that go to the ceiling. So that's important. But they, and sometimes, you know, we don't stand on ceremony. So sometimes it's an art room that is disabled for those 2 days that my clinician is there. Sometimes it's a computer room. Sometimes it's an office. It really depends. And I think that goes to, you know, our clinicians and mental health service providers being flexible about the setting that they're in and understanding that they're in somebody else's home, basically. And so we definitely find that you know, we're being flexible with them and they're being flexible with us. And, you know, I can say one of the things that I've noticed during the pandemic is that we no longer have to sell people in the same way about why this is useful. people get it now. They understand the impact of loss, and they understand what it's like for people to be disconnected from their loved ones. They understand mental health, I think, in a way that they didn't 2 years ago, because, even our governor was talking about being lonely and sad during the time, so it became kind of much more a part of everyday experiences, which is nice. I mean, not nice that everybody's suffering, but the suffering becomes more universal and people understand it. So it's much easier to go out to the community and say, hey, this might be useful. And they say, yes, yes, we understand why. So that's an easier sell.
Great, thank you, thank you. And Patrick.
Joanne, this is more of a comment, something to highlight. I think just the work that you presented is just an example of such a unique focus on developing and testing interventions that are about treatment engagement, whether it's adherence to antidepressant medication or starting mental health care. And it's just a unique way to think about a psychosocial intervention, I think, and how do you manualize that and make it structured and systematic. And it's kind of like systematizing good clinical care or good case management, whoever the provider may be. And also just a great example of, doing the research and moving on to dissemination that, as you so richly talked about, couldn't have happened without this great partnership with DIFTA and your other partners. And just again, a great example of research informing just really real world service. So it's not really a question, but just a comment and something to highlight.
I appreciate it. And it's actually interesting. So we have a program where we're working with case management agencies and providing mental health services there. And part of what I do when I go out and I introduce the service is I give them an introduction to Open Door, teaching them how to make a mental health referral. And I do it with the, humbly saying, case managers refer for all sorts of services all the time. But here's a strategy that we've used, that we've tested, that seems to be useful. Put this in your toolbox if it's helpful. And framing it for people in terms of this cost-benefit analysis and setting goals is really, I think, very helpful. And also, it's a health recommendation. We've all gotten health recommendations where we've kind of said, not really, So we're actually really trying to use it now as a resource. So it's not testing the dissemination, but we're using it. And I think people kind of get it. They understand why you might have to take some steps to get somebody into a mental health service. You can't just say, here, call this number and go, and expect success. So thank you. I appreciate it.
I'd like to encourage any others to write in questions. But in the meantime, I want to try to, this will be me trying to link your earlier research with things that are happening more recently. So please correct as needed. But I mean, is it possible, or is it the case even, have you discovered that being in the senior center, or even in the last 2 years with more prominence about mental health, mental illness symptoms, has stigma, I mean, is all of that decreasing stigma? Is that partly why there's such a high engagement? Maybe among other reasons.
Yeah, I mean, maybe, as I said, I do believe that the awareness of the toll, especially in New York, where we were traumatized by COVID, we got hit so hard early on, and Seattle did too. But, I feel like in New York City, everybody knew somebody, lost somebody. There were big challenges around vaccinations. And, now when I talk about, making health decisions, I always talk about vaccinations as well, because that's a health decision. So I do feel like there's more of a shared distress, if you will, and that then does make it kind of easier for people to accept this. It's not just me. So it could decrease the shame and the stigma associated with that. I don't have any data to say that. That's an impression. But I do feel like, as I said, when I go out to senior centers, nobody says, well, why would you bring a mental health program here? Case management agencies don't say, gee, why are you bringing mental health to us? They get it. And so I think, the shared loss, the shared anxieties that people are living with or have, experienced, I think has probably changed that for people. And again, you know, it'd be interesting to see what the data look like. I don't really know, but my subjective experience of this is that there really is an understanding of the role of mental health and mental health need in a way that we didn't have. You know, when we were launching the other senior centers earlier, you know, we would have to go in with a story about why, you know, why is mental health relevant to a senior center participant? You know, what's bad about having depression? We don't have to do that anymore. So I do think it's different.
Thank you. And a question. As I sort through this here, let's see. This, I'm going to just summarize this. I hope I got to the essence of this question that came in about changing roles, independence, that's maybe decreasing independence over time, changing relationships within families, how that perhaps being mistreated by others in life. I guess I'm not, maybe it's a comment on life transitions, role transitions, how that might affect accepting treatment or increasing risk of accepting treatment for depression or increasing risk of really abuse or maltreatment in older adults. This might just be more of a comment on sort of life transitions.
Right. Right, and yeah. So I think the person is also commenting on what's difficult about people who, yeah, right. So I think you know, elder abuse is pretty prominent. In, you know, nationally, it's 1 in 10 people have experienced it over their lifetime. And there's some recent data actually during COVID that the rates have increased, you know, because families have been locked in together in a way that's very challenging. And I think that what it's highlighted is the interdependence between family members who are living together, but also highlighted how hard it was to be able to help elder abuse victims, you know, kind of engage in self-protective behaviors, because especially during COVID, you know, where is my adult son going to go? You know, what's available to him? Because again, all of these services were shut down. So I think that was really hard. And I think it's always hard for older adults who are being victimized to acknowledge that there is a victimization going on. Right now, we're serving a lot of, as I said, there are a lot of women of color, mostly English speaking, and we spend a lot of time in the very diverse communities. And there are some communities where it's just, you can't even have this conversation. And so we're working to try and we're working with a South Asian agency that serves South Asian women to talk about elder abuse and depression. So I think that's what that person is getting at, both combinations of things.
Thank you for the response.
I don't know. So I appreciate the sensitivity. But
I know we're pushing right to 1 o'clock here, or 4 o'clock on the East Coast. And maybe a quick question. Are you observing other psychiatric disorders in this sample? Are you measuring that? Do you observe that? Do you see, are you screening for cognitive impairment? Are things surprising you?
You mean in the elder abuse sample?
Yes.
Yeah, so we, one of the things that we never set out to measure or treat was PTSD. We are seeing very high rates of PTSD. And, you know, because we're working in a diverse sample, it doesn't make a lot of sense for us to say to somebody who's got PTSD, you really should go to get the virtual reality treatment at Cornell. One of the things about New York is if you're a Brooklynite, you don't go to Manhattan. If you live in Queens, you don't go to Staten Island. People don't cross boroughs in the way that they could. So we began to just offer the services if they had depression and PTSD. And so we're beginning to see some reductions in those symptoms. So very high rates of trauma, very high rates of PTSD, not something we went looking for, but definitely something that we're beginning to observe. You know, is it more post-COVID than, you know, than pre? Again, I don't know. We'll see how the data is, but that was one of the things that we are beginning to see a lot of. that we didn't expect, and we're trying to address as best as we can. So
Thank you. Well, we're right at 1 o'clock here today. I want to thank Dr. Syrie for walking us through this research, talking over the current services and studies being done in the Alacrity Center and in other parts of your work. Thank you to Dr. Rowie for joining us to do the introduction and talk about your past collaborations. And we'll end Grand Rounds there today.
thank you.
Thank you.
Thank you for having me.
Bye.